Okay, so welcome everyone. We will cover the TherapyEd books, the new chapter today. So we're gonna start from the functional anatomy and biomechanics of the chapter. Of the book of TherapyEd of Musculoskeletal chapter number 2. Okay, so we'll go through the whole chapter. As much as we can do. Okay, so first, the topic is shoulder region. So in the shoulder region, there has been described about the osteology, arthrology, and the muscles, non-contractile structures, and all these tables related to the structure, the shoulder region. So we'll go through the whole things as much as we can. So here, during the starting of this topic lesson, they said the see figures 2.1, 2, 3, and 2.4. So here it is, the skeletal review, system anterior view. So we have already learned this in the medical school. So this is not new to us, just a review of all these structures which are related to the shoulder joint or the bones over here, the skeletal bones we know. And the muscles over here. So these are the common muscles. Superficially, you can see some muscles are deep muscles over here. They have already shown, I think. Okay, so go to the point of shoulder region. So this is here the osteologies. They say about the humerus, scapula, clavicle. So these are the bones which help to make this region, which is called shoulder region. Here, humerus, we know about this bone. So this is just we will have a review of all those things related to our joint, shoulder region. The bones over here. So you can see the proximal end of the humerus is approximately half a spheroid. And the articular surface is covered by hyaline cartilage. So the articular surface, which actually of the humerus or the humeral head, so that is covered by hyaline cartilage. Head is retroverted 20 degree to 30 degree, and the longitudinal axis of head is 135 degree from the axis of neck. So if we search for the humerus, so go for the image. You can see the humerus over here. The head of the humerus is not actually 100%, not fully 90 degree at all. What they say? They say that this is 135 degree from the axis of the neck. So if we watch the neck over here, you can see the neck is over here. So this is neck, and the head of the humerus is 135 degree from the axis of the neck. They just say it so. I think my screen is visible, I hope. Okay. So then what they say? About the scapula, large flat triangular bone that sits over 2nd to 7th ribs. Just we want to see that, we want to review this thing. As we know, here's the scapula. So you can see the scapula over here in this beautiful picture. I think this one is better. My turn is getting slow down. Okay, so here. So if I say the rib, if I count the rib from here, 1, 2, 3, 4, 5, 6, and 7. So what this age? This is a large flat triangular bone that sits over second to seventh ribs. So here is the second number rib. This is the first rib. This is the second rib, and from second to seven, it's situated on the six ribs. Okay. Costal surface and dorsal surface. So this got both surface called costal and the dorsal, which behind, the posterior view of the scapula, which is dorsal, and the costal is the anterior view. Three angles, we know, the medial, superior, and lateral. So this is medial. So for this age, medial, superior, and lateral, right? There's the lateral and medial and superior. Okay, so medial, superior, and lateral. Lateral angles bear the glenoid fossa, which faces anteriorly, laterally, and superiorly. Here it is. Then the pear-shaped fossa allows for freer range of motion in abduction and flexion. Concave shape receives the convex humeral head. So here the concave shape of the glenoid fossa of the scapula receives this convex shape of the humerus, right? Humeral head. Then orientation of the glenoid fossa places true abduction at 30° anterior to frontal plane. Now, clavicle, which extends laterally and links manubrium to acromion, connects shoulder complex to axial skeleton. I don't think so that it needs to be shown. This is so very much common, and we know about the clavicle. This is so easier term for a physiotherapist, I think. Arthrology. So we'll go to the arthrology perspective of the shoulder joint, where they said about 4 terminologies. Those are glenohumeral joint, sternoclavicular joint, acromioclavicular joint, and scapulothoracic joint. So glenohumeral joint, which is actually the glenoid cavity, glenoid fossa of the scapula and the humerus, which bind to form a new joint, which is called glenohumeral joint. Here, the convex humeral head articulates with the concave glenoid fossa. This is so simple, and glenoid fossa is very shallow. On the other hand, the sternoclavicular joint, where the convex superior inferior and concave anterior posterior articulates with reciprocal shape of the sternum, both articulates covered with fibrocartilage. Okay. Next, what they said about the acromioclavicular joint, a plain joint with relatively flat surface. On the terms of scapulothoracic joint, so this is a clinical articulation. This is not actually the original joint like others. Like if I open this picture from Google, so you can see here is the scapulothoracic joint. This is not actually connected joints like others, but it is connected with muscles, tendons over here. So this is a kind of clinical articulation, but not, or you can say the false articulation is not an original or true articulation of like the other joint, but we include this joint as the shoulder girdle arthrology joint, all those joints like glenohumeral joint, sternoclavicular joint, and acromioclavicular joint. With these 3 joints, we also count the scapulothoracic joint as a joint of shoulder girdle. Now comes to the point of muscles. So here the muscles are depressors, elevators, protractors, retractors, internal rotators, external rotators, flexors, abductors, adductor, and extensors. So they already mentioned the C table number 2-4. So here is 2-4. Here they said about the scapula, upward rotation is by the upper trapezius, shoulder shrug. The shrugging is done by upper trapezius. Shoulder horizontal adduction is done by pectoralis major and minor. Scapular downward rotation is done by pectoralis minor. Scapular shoulder protractors are serratus anterior, also the scapular upward rotators. Then scapular elevation, downward rotation is done by levator scapulae. This is very much easier terms. We know as a physiotherapist we have to memorize all these muscles, and in the practice lab, I think all the physiotherapists know these muscles. So this is not, I think, not very much needed to show individually. And the shoulder abductors are supraspinatus, shoulder lateral rotators are infraspinatus, shoulder medial rotators are latissimus dorsi, teres major, subscapularis, and pectoralis major. Abductors are flexors, and also the extensors are deltoids. So we know the abductor, shoulder abductor, if we say about in terms of deltoid, so the middle deltoid, the anterior deltoid helps to do the flexion, and the posterior deltoid portion of the deltoid helps to do the extension, and the middle portion of the deltoid muscle helps to do the shoulder abduction. And finally, the shoulder rotators is the muscle which is called teres minor. Here another muscle they have already written over here. Shoulder flexion and adduction, which is done by the coracobrachialis. Okay, so all these muscles we have already covered. You have to have the deep knowledge, I mean the memorization power to memorize all these muscles. Now come to the point of non-contractile structures. So we know about the contractile structures, which are included muscles and tendons. We know. So these two terms are given by the Jens P. Sirach's contractile structure, non-contractile structure for in the subject of orthopedic medicine. So there you can go through. So from Sirach, he said that there are two structures, which is one is called the contractile structure and the other is non-contractile structure. So the contractile structures are included with muscles and tendons, and all other structures, without muscles and tendons, all the structures of the bodies can be said as a non-contractile structure, like bone, bursa, ligaments, anything, or capsule, anything without, excluding muscle and tendon. So non-contractile structure, they said about glenohumeral joint capsule, ligaments, coracoacromial ligament, then glenohumeral ligament, transverse humeral ligament. So they said about these ligaments as non-contractile structures. Also, okay. Also, the labrum is included. So glenohumeral joint capsule, the first thing is capsule, then the ligaments, then labrum, and bursa. So this ABCD, these four structures are mentioned as non-contractile structure, which are capsule, ligaments, labrum, and bursa in the shoulder joint in this book. So under the non-contractile structure, the glenohumeral joint capsule, the capsule, which is glenohumeral joint capsule. So they say about something about this capsule, attaches medially to glenoid margin, glenoid labrum coracoid process, attaches laterally to humeral anatomical neck, and descends approximately 1 centimeter of the shaft, supported by tendons of supraspinatus, infraspinatus, teres minor, subscapularis, and long head of triceps below. And inferiorly, capsule is least supported and most lax. In the ligaments, they said about the coracohumeral ligament, base of coracoid process to greater and lesser tubercle of humerus. So this is coracohumeral ligament, base of the coracoid process to greater and lesser tubercle of the humerus. Then primary function of the coracohumeral ligament. You can see coraco, right? So it started from base of the coracoid process to the humerus. So that should be humerus, greater or lesser tubercle of the humerus. This is the origin insertion. You can see the origin insertion actually comes with the muscles. For the ligament, there is not actually like origin insertion, but for understanding this part, we can say the connectors. So the coracohumeral joint ligaments connected by the coracoid process of the scapula and the greater and lesser tubercle of the humerus. So they form the bone, the joint, not joint actually. So I can say I think you know about the ligament. Ligament is connectors of bone to bone. And the tendon is the connector of muscle to bone, right? So here, the coracohumeral ligament connect the scapula with the humerus using the structure of this coracoid process and the greater lesser tubercle of the humerus. So what is the primary function of coracohumeral ligament? The primary function of the coracohumeral ligament to reinforce biceps tendon, reinforce superior capsule, and prevent caudal dislocation of the humerus. So this so important functions over here. So this coracohumeral ligament reinforce biceps tendon, reinforce superior capsule, and prevent caudal dislocation of the humerus. Taught with external rotators, or I mean taught with external rotation. If taught, then the external, if it actually happens by external rotation, then coracoacromial ligament, a strong triangular ligament runs from the coracoid to acromion. Not a true ligament connects 2 points of same bone. So although this coracoacromial ligament, so this is as the part of the own scapula. I mean, the scapula got these 2 things. So this is not a true ligament as it connects 2 points of the same bone. So, but they're actually ligament as the scientists or all those medical personnel named it. Glenohumeral ligament, this is so important. Glenoid cavity this term comes from the scapula, glenoid, and humeral comes from the humerus. So this connector reinforce the glenohumeral joint capsule anteriorly and inferiorly. Superior glenohumeral ligament limits the external rotation and inferior translation. Middle one helps to limits the external rotation and anterior translation. Inferior glenohumeral ligament. There are 2 bands over here. You can see the anterior band and there is posterior band. The anterior band limits the external rotation, anterior and superior translation, and posterior band helps to limits the internal rotation and anterior translation. Transverse humeral ligament, this is a broad band passing over top of bicipital groove, acts as a retinaculum for long biceps tendon. So now come to the point of labrum, which is very much important topic or the structure of the shoulder region. Here, glenoid labrum is a fibrocartilaginous ring that depends the glenoid fossa. So this is a kind of ring, right? Attaches to capsule superiorly and inferiorly, as well as to the long head of the biceps tendon superiorly. Internal surface covered with articular cartilage, which is thicker peripherally, thinner centrally, aids in lubrication. This is much more important function. aids in lubrication as a meniscus of knee. So we know there is a similar kind of structure in the knee that is called meniscus and serves to protect the bone. So labrum is specifically, you can say that lubrication helps for what should I say, the easy-going movement or I mean the free movement of the joint is actually done by the labrum. Next is bursa. So multiple bursa found within this region. There's lots of bursa. If you search in Google, you can see all those bursi. Now the primary bursa involved with pathology in subacromial bursa, which is very common in clinical practice between deltoid and capsule, and also runs under the acromion and coracoacromial ligament and between the supraspinous tendon. So this is the primary bursa, which is subacromial bursa, bursitis, which is between the deltoid and capsule. Also, the underacromion and coracoacromial ligament and between the supraspinous tendon. Okay. So these were all these non-contractile structure of the shoulder. Now shoulder biomechanics. What they say over here, we want to go through. Glenohumeral joint arthrokinematics, osteokinematics occurs in opposite directions with elevation of humerus. Head of the humerus moves in an inferior direction because of convex moving on concave. So we know that earlier we had understood about the concave, convex, convex, concave method and convex, concave rules. So there we had understood that the glenohumeral joint, if I say over here, the glenohumeral joint, the glenoid fossa is the kind of concave surface and the humeral head is convex. So the rule of this convex, concave, or concave, convex, what it is, rule, if occurs in opposite direction with elevation of humerus, head of the humerus moves in an inferior direction because of convex moving on the concave. We had already understood this thing before in the prior lesson. Here, the rolling gliding occurs during elevation of the humerus so that the instantaneous center of the rotation varies considerably during the complete range. At approximately 75 degree of elevation, external rotation occurs, preventing compression of greater tubercle against the acromion. Okay. Now the scapulothoracic and glenohumeral rhythm. This is very much important for our physiotherapists to remember this thing in the clinical practice and to understand the biomechanics of the shoulder joint or scapulothoracic shoulder glenohumeral joint or what it is. So scapulohumeral rhythm, this is also called the scapulohumeral rhythm, is a ratio of movement of the glenohumeral with scapulothoracic joint. Maximum range is between 150 degree to 180. The glenohumeral joint contributes 100 degree to 120 degree of flexion and 90 to 120 degree of abduction. And overall 2:1 ratio of glenohumeral scapulothoracic motion is described, although substantial variability exists between individuals. The first 30 degree to 60 degree of elevation occurs mainly in glenohumeral joint. Requirements of full elevation were the sage, the scapular stabilization, inferior glide of humerus, external rotation of humerus, rotation of the clavicle and sternoclavicular joint, scapular abduction and lateral rotation of acromioclavicular joint, strengthening of thoracic kyphosis. So these are the important notes or the topics to remember for requirement of full elevation. If the joint wants to do the full elevation, there should be present of scapular stabilization, inferior glide of the humerus, that should be okay. Then external rotation of the humerus, the rotation of the clavicle at sternoclavicular joint, scapular abduction and lateral rotation of acromioclavicular joint, and strengthening of thoracic kyphosis, which is very much important to do a full elevation. That's for today. We will cover the next algorithm in our next video. Thank you so much for watching. Let's subscribe the channel for getting all the updates and go through the book chapters of TherapyEd. Thank you.